And today I'm very proud to be introducing Dr. Sunny Steinmeyer, who is a PhD psychologist who I've known for almost 30 years. She has served as a psychologist and counselor for eating disorders at Capel by the Sea Hospital in Dana Point and at South Coast Hospital in Laguna Beach for many years. Prior to my inviting her to come to Sovereign Health to take over as the program director for the eating disorder program here. She has, as I said, I've known her 30 years. Apparently she has 30 years of experience in treating eating disorders. So right after she completed her PhD, I met her. She has a master's in psychology from Edinburgh State College in Edinburgh, Pennsylvania, which she completed in 1978, and a PhD from the United States International University in San Diego, California, and she completed in 1986. She also maintains a private practice in Laguna Hills. So without any further ado, let me introduce Dr. Steinmeyer.
Thank you. I don't need that.
Okay.
I'm wired, I'm told.
Okay.
They showed me, obviously it's on, I gather. They showed me that this mic has a mute button, and it occurred to me that my children would have loved to have known that. I'm delighted that everybody is here. I am, as Dr. Snyder said, the veteran of several years of experience in eating disorder treatment. And I would like to hope that I can share some of the product of that experience with you today in an effective way. My goals are to to give you an overview of the difference between eating disorder and normal, which is often a conflict for folks, to also to help you understand what it feels like to be an eating disorder. As long as I've been in this field, I'm still surprised at the kinds of experiences my clients share with me. To give an example, I was working with a young woman who was an inpatient in another program, and I went over to see her one weekend, and she was complaining about the interactions that she'd had with the staff, the nursing staff. She said, they want to make me feel better, and they want to find out things about me. They were talking to me about what movies I'd gone to. She said, they don't understand. The eating disorder is what I do. I haven't seen a movie in 2 years. That was one of the moments that I thought, I really didn't know what it was like, but those moments have taught me. We're also going to talk some about the demographics, how eating disorders differ in development and in treatment from substance abuse. We'll talk about the specific categories of eating disorders and some of the treatment strategies that we use here at Sovereign Health. I should also tell you that I am joining the 21st century, and this is the first time I've ever done a PowerPoint, so we'll see how this works. Okay. From my perspective, let's talk about what an eating disorder is not. First of all, it is not, from my point of view, a disease. That is, it has no known medical or physiological antecedent, or it has no pathogen, and moreover, the treatment is behavioral, not medical. Second of all, it is not a choice. I don't know of anybody who says, I don't have much to do in the next 3 years. I think I'll spend them getting treatment for an eating disorder. It is also not a moral lapse. It is not a matter of poor willpower. As a matter of fact, people with eating disorders have more willpower than almost any other folk I know. It is also not a life sentence or a death sentence. People do get well. Whether or not you treat eating disorders, whether or not you have ever worked with eating disorders, whether or not you've ever had an eating disorder, I would make my maximum bet of 50 cents that you know somebody who has an eating disorder. Let's talk about what it is. Click. It is a functional abnormality involving a complex interaction of various medical, mental, physical, and social factors. It has no predictable course or cause, and for which treatment is a function of learning, and it's basically up to the client in that he or she must cooperate. None of those, of course, or that complex does not hold true for medical diagnosis. One of the major questions, I think, for people who wonder about themselves or wonder about the people that they love as to whether or not they have an eating disorder is, when is it normal, when is it an eating disorder? You have a single sheet that discusses this to some degree, but the point is that unlike substance abuse behaviors or eating disorder behaviors are an absolute continuity of normal. Every eating disorder behavior is a part of what happens to us normally. We may not enjoy it, but every one of us has had to throw up on occasion. I would like to hope that everybody in the room has had the experience of watching an exciting movie or a football game on television with a bag of chips beside them, and an hour later turning to the chips and discovering they're empty and having no idea where they went, except there are crumbs all over. If eating too much is a sign of aberrant behavior, then after Thanksgiving we all should be ashamed of ourselves. Moreover, just as an experiment, let me ask in the room, if you are under stress, how many of you are more likely to eat too much of something? If you're under stress, how many of you are more likely to not eat? Is there anybody in this room that didn't raise their hand to either alternative? One, okay. My point is, most of us act out with food in reference to stress. Some of us eat too much, some of us can't eat. But do we all have eating disorders? Of course not. Deb McCarthy, our dietitian who's over there, has a way of looking at it. She says eating disorder behaviors become suspect after 3 strikes. If somebody binges once in a week or so, not a big deal. Twice, 3 times, it's an eating disorder. It's a matter of concern. I seem to be getting some static somewhere. Another area in which we share a common bond with our eating disordered brothers and sisters is with reference to our attitudes when it comes to negative self-perception. Although again, it's a matter of degree. Did anybody go to the mirror this morning and look and say, "Wow, is the world a lucky place because I'm in it"? Every morning I go to the mirror and I'm disappointed. Every morning I want the mirror to tell me that I look 10 pounds lighter and at least 15 years younger. And every morning the mirror goes, "It ain't going to happen, honey." Not only that, but at the risk of sounding slightly psychotic, I am convinced that there are shadows behind my image of the mirror that have little messages to them. You didn't do that. Remember that writing that you're working on? When are you going to get to that? You haven't called. All of those promises, all of those disappointments are all hanging out in the back of my mirror. Terrible way to start a day, but I don't think I'm the only one who's got them. But the difference between me and folks who have an eating disorder is that I know that when I turn my back on my mirror and I walk out of the bathroom and I turn out the light, I'm the only one who was disappointed. I'm the only one who wanted to see something different. If I walked in today and my colleagues here at and I really did get my mirror wish, and my colleagues here discovered that I looked 10 years younger and 15 pounds lighter, or whichever way that went, they would say, "What happened to you?" They wouldn't want that. Now, the difference between me and people with eating disorders is that they don't like what they see in the mirror either. But they believe that that's what everybody else sees. That sandwich that they ate at lunch that is now distending their belly or is now adding inches to their thighs as they sit there in class is perfectly obvious to everybody else and is rendering them disgusting. So again, it isn't a matter of the what, it's to what degree. And I think sometimes we mislead the people that we're working with and we say, oh, you must learn to love yourself and really like your image. Well, quite frankly, I have not been able to look in the mirror and say, I love what you look like for a long time. And I don't think it's going to happen anytime soon. But I think being able to share that with people and say, here's the difference. The difference is nobody else sees that. To get back to, however, these extensions of normalcy, it's important to remember that when exaggerated and out of control, these normal experiences can produce severe emotional, physical, and social complications, medical conditions, and even death. Let's look at characteristics of eating disorders in general. First of all, an abnormal and harmful food-related behaviors, such as restricting or binging, purging, overexercise, laxative or purgative abuse, and insulin abuse in diabetics. We'll get to that in a bit. Moreover, unhealthy beliefs, obsessions, perceptions, and expectations about food, weight, and body shape. Finally, damage to careers and relationships, and of course, potential long-term health problems and life-threatening illness and even death. This business about unhealthy relationships or unhealthy beliefs and obsessions. We once had a young woman in a program that I was working in, and we were in a group one time. I don't remember how the subject of traveling came up, but she commented that she had spent 6 weeks in Europe the summer before. She said, you know, I don't remember any of the countries we visited or anything we did, but I can remember every meal I ate. Ugh. To say that relationships are impacted by eating disorders is to put it mildly. Anybody who's ever been in a relationship with somebody who has an eating disorder, that means parent, kid, spouse, it becomes clear that the eating disorder is number one. Anybody else or anything else comes secondary. I've known of mothers to leave their babies in the crib while they go and spend a couple of hours binging and purging, knowing that what they're doing is not good mothering. But at that moment, mothering is not as important as their relationship with their eating disorder. And of course, imagine I was in this field at the time, and I came upstairs. My son was 19 or 20, and I was on the phone to one of his many girlfriends, apparently, and I heard him say, "Why should I take you out for a big dinner to celebrate your birthday when you're just going to go and throw it up?" So he had already obviously had some early experience with the impact of eating disorders on relationships. And he realized gratefully that that probably wasn't the best relationship material. When the idea of distortions becomes so significant that I think we don't realize to what degree everything becomes about food. Let me go on to some of the strengths that eating disorder people have, because this is a very important thing to remember. They're often very intelligent, tenacious, accomplished, attractive, sometimes self-absorbed, sometimes accommodating to a fault, and also perfectionistic. They're generally extremely rational and honest. You can believe them if they report on the stock market, if they tell you about something that they learned in class or something that they did at work. But when it comes to body image and food and self-esteem, their distortions of the truth are astonishing. And their perceptions become almost psychotic in proportion. I was working with two young women in a program, and they'd been in the program for some time. They were both roughly about 19 or 20 years old, and they had been competing with each other. I think they were plus or minus an inch or two, maybe around my height, and they weighed roughly 85 pounds. They were off from each other's weight by, again, a pound or two. They'd been competing. And one of them said to the other, "I get so worried when I look at you. You look terrible. You look so thin." And we said, "What do you see when you look at you?" "I've got this fat right here." They were almost identical. But as I said, there are times when I think this is almost psychotic. Well then, more about how does it feel to have an eating disorder. We've talked a little bit about body dysmorphia, or being discontent with one's physical appearance, preoccupied and by a perceived defect in physical features. For example, the belief that fat appears immediately after eating, and that any perceived flaw is a major cause for public shame. Any abdominal swelling, for example, even from water, is fat. You know, in this case, I tend to think a lot about metaphors, and it's very clear that the metaphor here, fat, is a metaphor for unacceptable. And we have to help them realize that and get off of the fat word. I had somebody bring this to mind in another situation altogether one time. Before I was working with eating disorders, I worked with transgender clients, and one day one of the transgendered now women that I had worked with came into my office. She said, "I've had a terrible day." I said, "Really?" She said, "Yeah, it started out bad this morning when I got on the scale." She said, "It was just awful." I said, "What do you mean?" She said, "Well, I feel so masculine." I said, "Masculine?" She said, "Yeah, I gained 5 pounds. In her world, to be masculine was unacceptable. She didn't feel fat. She felt masculine, which is a great example of how arbitrary our use of the word fat is. It's about being unacceptable. It has nothing to do with fat. Food takes on many roles in an eating disorder. It can be a means of self-punishment. One patient we had who was anorexic in a program that many years ago would eat a large mound of cottage cheese. That was about the only thing she would eat. That doesn't sound too bad. Imagine cottage cheese with about 15 packets of equal, and a liberal spreading of mustard. She literally punished herself to eat. To enjoy food would make her feel guilty. Food can be a form of self-assessment. I've had people say, "It was really a good day. I feel like a success. I only ate 500 calories. You know, not about what did you accomplish, not about who did you see, not about who did you love. I ate 500 calories. Food is a form of stress release and or a way to mask unacceptable feelings. I'm sure those of us who work in the industry have had many experiences of folks who are very overweight but are very sweet, very pleasant, and totally unaware of their anger. And somebody the other day, she weighs probably about 300 pounds, and she was so excited. She finally told a receptionist who had been very abrasive to her that she didn't like her behavior. And she said, I came away, I got in the car, and I started to hit myself because I'd done something bad. And then I realized that you told me that it's important for me to stand up for myself. And of course, I was all but cheering. And I said, what did you do when you went home? Took the dog for a walk and had a nap. She didn't eat. She's finally being able to say, I'm angry. Food can be a form of, in an environment of self-neglect or denial, it can be a form of reward. I'm thinking of a woman who was about 70, 75 years old, who'd had a lifelong eating disorder, and who was sitting in my office, and she was interesting. She was a very wealthy and very, very successful musician. And one day she started to cry, and we had been talking about the fact that everything that she bought had to be on sale. Everything, and if she bought anything special for herself, it had to either be in sale or the large bag or the economy size or whatever. And she would shop at length for the cheaper bag or whatever. The woman could have bought and sold, most of us in the room. And one day she started to cry, and she said, I realize that my sweets and my treats are the only good thing I'll allow myself. She's now paying for a cruise. Yes! Food is also a response to the illusion of being controlled. For example, the adult woman who sneaks a candy bar to her room, or who, when she goes grocery shopping, buys a bag of Reese's Pieces and eats them furtively in her car and disposes of the evidence. The idea that she wasn't supposed to have those things, and she can have them, she can break the controls. They can't control her. They can't tell me what I can't have. And of course, she realizes that those days are from long ago, and that's something that she's working on. Food is also a thermometer. And by that I mean here in the eating disorder program, and if you've ever worked with somebody or lived with somebody who had an eating disorder, food tends to be your measurement. Even in our staff meetings, we'll talk about the fact that somebody has finally gained so much, or has been able to go out on our food challenge and eat a dessert. Or we talk about food as if it means something. It does, but it's the thermometer. It's like a thermometer that tells you the temperature, and it tells you that the temperature is now approaching normal, that people are getting back to being healthier. It does not, however, describe the disorder or say that the disorder is cured, but it is our thermometer. Let me just share with you something briefly about case histories. When I first started in this line of work, we were all told that eating disordered women, and they were of course always women, and they were of course always young. Anyway, that they all came from families in which the mother was over-controlling and the father was absent, emotionally if not physically. It was interesting. I began to see some people that didn't fit. Or then it was that the mother gave no controls. It was a child herself, and it was up to the child to figure out limits and controls, and that was why she became an eating disorder. Moms were getting a bad rap all around. Of course, it isn't that simple. But the bottom line is that mothers do have some influence in that there is some evidence to support that girls with eating disorders, or girls are more likely to develop eating disorders in a family where mom diets continuously, or where food and weight are the subject of a great deal of interest from the mother. More likely, it's not a cause. Eating disorders are also frequently associated with traumatic events in children. We had somebody here not long ago who had, as a kid, experienced a traumatic rape. And her sense of herself was that she was now not worth very much. And so she mistreated herself with food. Another response to rape, to trauma, not necessarily rape, is what I call the best little girl syndrome. Actually, it could be the best little kid syndrome, but what it amounts to is, imagine this little girl bopping down the street, and she's doing the best she can to be the best little girl that she can be, and then this terrible thing happens. We'll make it a rape, or in fact, it could be, the death of a parent or something awful. And now we have this little girl who has a dilemma. She can look at the situation and say, wow, I was bopping along being the best little girl I could be, and good things happen to good people, and this awful thing happened to me. So maybe it means that no matter how good I am, the world is a place in which random things happen and crappy stuff will just get dumped on my doorstep no matter how hard I try. Option 1. Option 2. Bopping down the street, being the best little girl she can be, traumatic event happens. Wow. I thought I was being the best little girl I could be, and look what happened. And good things happen to good people. But a bad thing happened to me. So I just must not have been good enough. I'll have to try harder. And we have the perfectionistic syndrome, which we see so often with eating disorders. Have to try harder. Have to be the best little girl. Now here's a ringer. The best of families. One of the dietitians that I was working with for a few years, and we had some patients in common, we started to talk about how interesting this was that we saw this history. The typical, we saw several patients who all fit this profile. One, they were single children, or maybe one of two, and the other one was probably a girl. 2. Mom and dad were married in a successful marriage. 3. The daughter was a 4-point plus student and considered to be a school leader. 4. She was involved in community affairs. 5. The family was financially comfortable enough to afford dance camp or cheerleading uniforms or ballet lessons, but not so well off as to be lavish. And these girls had eating disorders. Does anybody want to make a guess as to what was going on? I'm not hiding anything from you, by the way.
Best little girl syndrome.
Yeah, but nothing bad has happened. As a matter of fact, that's the point. These girls had never, ever experienced trauma, catastrophe, or failure. They didn't know what it was like not to succeed. They didn't have a family pattern. I'm not suggesting that everybody who has a family of youngsters go off and create something, but I am saying that crisis and catastrophe and failure are marvelous teachers, because once you come out the other end, you can say, look at what can happen and I can be okay. But if that has never been your pattern, if you've never seen anybody in the family go through it, then the assumption is that our family doesn't have those things. I had a young woman I'd worked with who was really a severe anorexic, and she'd been on tube feedings, in fact, in a hospital before we got her. She was in our program for a while, and then she was an outpatient, and finally she felt well enough to go back to school, and she'd been at USB, I'll get it, and now she was at Pepperdine. And I got a crisis call from her one day, sobbing, "Sonny, please call me back." So when I had a break, I called her, and, "Honey, what is it?" She said, she just kept sobbing. She said, "It's so hard. It's so hard. I can't do it. I'm not going to be able to do it." And this is between many sobs. And I said, "Sarah, did you just take a test or get a paper back or something?" More sobs. "What was the subject, honey?" "My favorite, history." "What did you get?" More sobs. "B." She didn't have any history with failure. And her parents, by the way, in my presence, and she told me this, would say, "Go to college and make some B's and have fun," but she didn't know what that meant. She really didn't. The long part of that story is that about, maybe 5 years later, I was shopping up at, Fashion Island, and I heard "Sonny," and I turned around, and she comes flying up to me, throws her arms around me, and said, "I finished at Cal State Fullerton. I am a teacher, and I made B's." I was delighted. There's also some reason to believe, of course, that there's a genetic component, and that mothers of eating disorders often have, or sometimes, eating disordered mothers sometimes produce eating disordered daughters. I have a family where the grandmother was an anorexic, the mother is overweight, and the daughter is anorexic. Interesting. But again, I haven't seen any research that clearly ferrets out how much of this is social influence, familial influence, and genetics. I don't think they have been able to pinpoint that yet. Okay. Let's look at some demographics. It is estimated that there are 8 million Americans that have an eating disorder, 7 million of whom are women and 1 million of whom are men. It is no longer a woman's disease. And by the way, this is where men are concerned, that's probably underreported. Again, a number of probably 10 to 15% of the population are men. 95% of those who have an eating disorder are between the ages of 12 and 25. And I think that's an important statistic, but I also think that it's misleading, because in our program we have certainly had our share of women who were older than 35. I've seen that in every program I've worked in. As I said, I've had somebody in my practice who was 70 plus. And so I think it is misleading, because I think sometimes we don't tend to think that an older person can have an eating disorder when in fact she's just spent many years hiding it. Also that the rates among minorities are essentially the same as they are. Access to treatment. Only 1 in 10 people with an eating disorder receives treatment. It's estimated that individuals with eating disorders need anywhere from 3 to 6 months of inpatient care. Health insurance companies, for several reasons, and we of course all know about those, do not typically cover the cost of treating eating disorders or fail to do so adequately. I'm always amazed at the insurance company that says, "Well, you say that she's only binging once a day now, she should be fine," What? The cost of outpatient treatment, including therapy and medical monitoring, can extend to $100,000 or more. Okay. Let's review some specific eating disorder syndromes. But before I get to that, is there anything, I haven't asked for questions, and by all means feel free to ask. Is there anything yes?
How significant does the trauma have to be?
I think that's a really interesting question. And I think the answer to that is significant to whoever.
Because you have real trauma and you have perceived trauma.
I think perceived trauma, I think the response is still the same. The dynamics can still be the same. And we all have worked with folks who, I can think of somebody or some people I've known who went through amazing things, and they're here because they're somewhat depressed. And then I've known people who also went through things that were not nearly so serious, and they are reacting to it very seriously. And so I think it has something to do not only with the trauma, but, for want of a better term, the constitution of the individual who experiences it.
understand maybe that they have experienced trauma in the family, but it's just never been talked about? Or
I think sometimes how a family handles trauma, yes, is important, sure. And I think not necessarily with reference to eating disorders, but just in general, absolutely. If a trauma is ignored, it becomes much more difficult to deal with. Mm-hmm. Any other questions? Okay. Before we get to the specific ones, I want to make up the point that it is not unusual for an individual to gravitate from one syndrome to another, anorexia to bulimia, etc. Moreover, the following patterns are often complicated by the presence of other diagnoses such as addictions to substances, shopping, sexual behaviors, depression, obsessive-compulsive disorder behaviors are not uncommon. Okay, anorexia. An obvious loss in body weight, such that the individual is 15% or more below the average body weight for his or her height and age. A preoccupation with being thin, while at the same time insisting that he or she is fat. And again, the word fat, if you substitute inadequate or unacceptable, it makes it a lot more sense. Denial of hunger and avoiding eating meals in the presence of others, and also lying to you when they tell you that they have. Obsession with nutritional values such that fats and carbohydrates are avoided, and unusual food rituals like cutting food into tiny bites, eating foods in a particular order, and so on. It's the rituals that these folks can generate are just amazing, and helping them get past those patterns of behavior is a major struggle sometimes. Anorexia can result in osteoporosis, infertility, organ failure, especially the heart and kidneys, and at its extreme, it can be fatal. One of the things that this doesn't list is brain function. Apparently, the brain is composed primarily of lipoid tissue, and it is the brain that suffers a great deal, although of course silently, when in the presence of severe anorexia. And in dealing with these folks, they will have a history that suggests that they are really bright, and yet they're not capable of complex cognition in the least, and it's like talking to somebody who's just not there. I just came across an article that said that the research supports that when anorexic folks are renourished, their brain tissue gets in balance, and the brain actually gains weight. But I didn't really need to see that in order to know that when these people are renourished, they start talking, and they are able to go to more than a superficial level of discussion about things, and their memory is much better. Bulimia. There are no weight qualifications for bulimia. They can be average or overweight. They have recurrent episodes of binge eating, which may last 2 hours or more, and in which more than 10,000 calories can be consumed, costing as much as $100 a day. And I had a patient that took years paying off a credit card bill. It was her binge food. She could eat an entire box of Krispy Kreme donuts in milliseconds. It was kind of good for me because donuts could be really tempting for me, and there's a Krispy Kreme shop just across the street from my office. But after I worked with her, they ceased to have their appeal. Binge episodes are followed by some form of compensating behavior, such as vomiting, over exercising, or laxative abuse in particular. In this concept about a binge being like 10,000 calories or more, people will say, oh, I really binged last night. What'd you have? Oh, I ate a box of popcorn, and then I had a bunch of strawberries, and then I even had some ice cream. Well, it sounds like a lot of food, and probably not the best food choices, but that isn't a binge. It's interesting, binges are often carried out without any reference to taste. I mean, imagine somebody sitting down with a box of cake mix and eating it out of the box with a spoon. And inordinate amounts of food will be consumed in a very short period of time without reference to taste or certainly any pleasure. The binge purge cycles continue or take place in response to negative feelings, especially guilt or anger. Bulimia can result in severe dental erosion, gastrointestinal disorders, esophageal ulcers, blood pressure, and heart irregularities. We had a patient who was being groomed as an Olympic swimmer. And because of the damage she did with Ipecac over a period of a couple of years, she was disqualified because of heart valve problems. Compulsive overeating or binge eating disorder. These people are often overweight. Large amounts of food are consumed in a short period of time, usually in secret. They do not make compensating efforts. They are often associated with unfulfilled needs for affection or validation. Food equals comfort. And binges produce intense feeling of guilt and shame. Incidentally, that food equals comfort, I heard this on NPR yesterday on their money section. I don't remember what the connection was, but some researchers have discovered, and I thought, discovered like it's new, but that heavily fatty foods truly are soothing. And their research involved presenting folks with a sad movie, I believe, or sad stories, and then providing a placebo for one group and fatty foods for the other. And the group that received the fatty foods felt much more comforted, and their mood was much more elevated compared to the group that got the placebo. Somehow that isn't a surprise. Anyway, compulsive overeating disorders can result in diabetes, high cholesterol, and other health problems associated with obesity. Now, I'm going to offer a couple of new ones. They're not in the DSMs and are not formally recognized, but I think they should be functionally recognized. I actually know somebody like this, and probably some of you do too. Compulsive overeating can result in, we talked about that. Anyway, here we go. Orthorexia. As I said, it's just sort of an interesting one. It was originally described by Stephen Bratman, MD, in 1997. The individual may go hungry rather than eat what does not meet healthy criteria. It's motivated by a desire to feel healthy or pure rather than to lose weight. Research and food preparation are time-consuming and often socially limiting. And food is selected for its purity rather than taste preference. It's an interesting disorder. It may result in medical complications associated with malnutrition and starvation. I don't know what that is. It's often complicated by co-occurring disorders such as depression, substance abuse, or OCD. If you know anybody who fits this profile, it seems to be they're pretty limited in other areas of their life also in terms of what they'll find acceptable for recreation and so on. But it's just real interesting. It's about purity. It's about healthy, wholesome. And of course, by definition, that's pretty much fat limited. So malnutrition is not uncommon. The other one is diabulimia. We had a patient like this Mission Hospital many years ago, or in South Coast, only it wasn't named at the time. It's not officially a recognized term, but the concept was derived by Anne Goebel-Faby, a PhD. It refers to women with type 1 diabetes who deliberately skip or reduce insulin in order to lose weight. Man, talk about Russian roulette. The population is 2.5 times more likely than other women to develop an eating disorder. They literally manipulate and eat according to how much insulin they're going to give themselves, or play with their insulin and with reference to what they're eating. Trying to keep track of these people medically is just a nightmare. It can result in, yeah.
By this population, did you mean people with diabetes or specifically people with bulimia?
I think women with diabetes. I'm sorry, that is a good question. Type 1 diabetes. Long-term damage it produces long-term damage to kidney, nerves, and the circulatory system, blindness or the need for amputations, and a high risk of coma. Any questions about the categories? No? Okay. Okay, some treatment considerations. How do eating disorders and substance abuse treatment differ? This is an important area because I think we get a lot of confusion. The first, and I think the most significant difference is our goal. Somebody put this to me very well. They said if the goal of alcoholism treatment was the same goal as for eating disorders, then an alcoholic should be able, after treatment, to walk into a bar 3 to 5 times a day and order 1 drink. The point is, the goal of alcoholism or substance abuse treatment is abstinence. That's not the goal of eating disorder treatment. The target item or the target substance in substance abuse treatment is not something that we naturally need. There is no natural need to have a drink. There is no natural need to have cocaine or any of the other substances. But of course, food is essential. As a byproduct of this difference in treatment, we also have a different attitude toward relapse. We expect relapse in eating disorder patients. It's inconceivable that somebody would come into a program and say, okay, I'm all done, I'm not going to do that, and could go for weeks or months without engaging in those behaviors. It's impossible. As a matter of fact, we had a young woman who had been in our program once, and she was bulimic, and she was anorexic, but with bulimia, as I said, people can switch and can combine the symptoms. So she was an anorexic who kept her weight down in part by purging. Anyway, she came back to us for another course of treatment. She's one of the angriest young women I think I've ever met. And she marched into the room, and I can still see her, and she said, now, purging is not an option. I will not purge again. And she showed up every day for treatment, essentially like this. And you could see, look at her face and read, purging is not an option, purging is not an option, purging is not an option. And I looked at her one day and I said, I wish to heaven you would. Because she was so determined not to purge that she was missing out on treatment. She wasn't getting anything. She wasn't learning where this impulse was coming from. She wasn't learning how to manage the anger and the resentment that was buried inside. All she was thinking about is, I will not purge, I will not purge, I will not purge. I think she left the program not having purged, but with not much improvement either. In this program and in many of the other programs with which I've been associated with, we're not 12-step oriented. We're more invested in cognitive strategies that explore past behaviors and past patterns. Although we do certainly offer OA and 12-step support adjunctively. Also, being in recovery or a history of eating disorder treatment is not a prerequisite for being a therapist in this field. I'm somebody who's had a couple of bouts of being overweight and have lost weight, but I've never been an eating disorder. I don't think that disqualifies me, however, from practicing in the field. We don't assume that that is the only way that people can come to work with this population. I think in part because, again, the dynamics that drive an eating disorder are all based on thoughts and behavior patterns. They are not based on food. And they are thoughts and behavior patterns that are common to a wide range of mental health issues. So the very basis of treatment is different. Any questions about that? Uh-huh.
So you said that you guys don't believe in the 12 steps and that kind of approach therapy, but that you send your patients to OA meetings?
It isn't that we don't believe in, it isn't a matter of faith. Our program has a different approach. We use cognitive behavioral strategies and some holistic and other options, which I'll get to. I don't think there's one way to recovery. And certainly for folks for whom OA or 12-step programs are effective, we offer that as well. But it's not the basis of our program. Does that help? The treatment philosophy here at Severn Health, and actually was consistent with other programs I've been a part of, is we incorporate elements from mental health or substance abuse. First of all, once again, to point out that we often don't see an eating disorder that is struggling with an eating disorder in isolation. They often have mental health issues such as depression, substance abuse, OCD, and so on. So we make an effort to individualize our treatment so that we can bring in elements from mental health or substance abuse components as indicated. We use a cognitive behavioral approach in which old ideas are challenged and behavioral risks are taken with reference to food in the presence of support. One of the most, here at Severn, one of the most significant events that our patients talk about is the Starbucks challenge, where Deb takes them to Starbucks and they each choose a dessert. And then they share those desserts in bites, and then they rate the dessert in terms of how they liked it in order to help people get past the idea that sugar is bad. We don't believe in any bad foods, and in fact encourage our patients to have an experience with the entire range of foods, including pizza and treats. Attention is paid to the individual strengths and the small triumphs throughout treatment. I'm absolutely convinced that if we don't pay attention to the moments of success on small challenges, we'll never get to the big ones. And we ask sometimes patients to keep a success journal, a success being defined as anything that's difficult for you that you managed that day. It may not have been hard the day before, so you ignored it. That day it was hard, it's a success. And finally, we reinforce that the individual, not the program, nor the therapist, is in control. That position is emphasized throughout. Because after all, this is a disorder of perceived control. And for patients to feel as if they are surrendering or in control to us, first of all, it puts us in the driver's seat where none of us want to be. And second of all, and I think this is the worst of it, when they leave here, they feel that their treatment has been left behind, that we were responsible for their improvement, not them. And they walk out as naked as they were when they came in. But if in fact we can remind them that nobody made them eat anything, nobody made them take that risk in group, nobody made them eat a bite of a brownie at Starbucks, they were the ones who did all that, then they can realize that these are strengths that are in their own quiver and that they're taking out with them. In addition to the cognitive behavioral aspects of the program that I've just identified, we also have individual meal plan and education regarding the exchange system and intuitive eating. Challenge foods and situations are revisited, and again, there's support with the idea that there's no bad food. And the goal is to normalize the eating patterns and to reduce food-related fears. To assist us in helping patients become stronger in these regards, we offer some other things. We've had some very exciting responses to equine therapy, working with horses who are rescue horses, and under the supervision of therapists who are equine experts in addition to being licensed mental health practitioners. It isn't just a matter of riding the horse, it's a matter of bonding with the horse and discovering that one can have a close connection to another living thing that doesn't demand anything. A horse doesn't ask for perfection. We also have holistic practices such as yoga, meditation, and biofeedback. And we have a very exciting neurobehavioral program in which individuals engage in state-of-the-art computer programming that facilitates new and healthier thought patterns. That summarizes pretty much the eating disorders experience I've had and the eating disorder treatment that we offer here. Again, I'd like to toss it open for any further questions. Yeah.
Sonny, thanks for that talk. It was fantastic. You know that my primary interest in the transformative effect of meditation in patients with eating disorders and other conditions.
Uh-huh.
And you mentioned that the eating disorder really is a disease of perceived control, and that if they begin to behave more naturally, they're fearful that they're going to lose control, and that the world will come apart at the seams. And so I'm sure there are studies regarding using meditation as a primary treatment modality for helping patients transform their image of the need to be in control and to surrender. The act of surrendering control, in fact, is what meditation is all about. Mm-hmm. So do you have any information on that? Has that been utilized? Are there any studies showing that meditation has any positive effect?
I know that meditation and yoga are I've heard that they have a very positive effect. I'm not aware of the research. I haven't explored that. Be interesting to look for.
Well, we'll have to do that research then.
Yes.
The other thing is I want to put a plug in for Sovereign because when patients come into Sovereign, the cognitive testing that's done under one of the online sites called CogTest is a pre-assessment of cognition as a patient comes into Sovereign. And at the end of treatment, we can also do CogTest and see if there's a transformative effect if the cognition improves, as nutrition improves and as they've gone through therapy. We're kind of in the process of getting that information and collecting that data, but that outcome data would be very important to see.
Absolutely.
How that is affected.
It really would be interesting if we separated out the people who came in severely undernourished, and paid particular attention to those folks. Yeah, exciting. Yeah.
Have you heard of dolphins ever being used for like equine therapy and therapy for eating disorder?
I think that would be a wonderful idea. It's just that it's pretty hard to get easy access to dolphins. But I can imagine that they would be marvelously restorative.
Well, the only reason why I mention it is a lot of this therapy is being used for autism.
Yes, yes.
And it's a cognitive thing.
You know,
Alzheimer's.
I'm wondering if there's some eating disorder programs in Hawaii that are working with dolphins.
There used to be, and I'm not sure if it's still there, there used to be an eating disorder program in Florida that worked with dolphins.
I think that would be a great idea. I'm wondering if we could ask Dr. Sharma for some dolphins. Any other thoughts? or questions? Well, I appreciate your attention. I hope that this has been of some use, and I've certainly enjoyed the experience of being here and experiencing my very first efforts with online work.
I just wanted to thank everyone again for coming this afternoon, and thank you Sovereign Health for hosting us all for the lunch and the lecture. A couple of reminders that if you're wanting your CE certificate, you can take your completed paperwork back to the registration table and we'll get that for you. And please make sure to grab the flyers for the Sovereign Health Open House event in Lake Arrowhead on August 25th. And then the next luncheon, like I mentioned before, is Wednesday, September 14th. And if you want to mark your calendar, it's always the second Wednesday of the month. But next month, our guest speaker is going to be Candy Finnegan, the interventionist.